A very good evening to all of you. First of all, on this auspicious day, I, Hetal Gohil, on the behalf of Hetero Healthcare, take this opportunity to wish you all a very happy Guru Purnima. Guru Brahma, Guru Vishnu, Guru Devo Maheshwara, Guru Sakshat Parabrahma, Tasmai Shri Guruve Namaha. Thank you to all the gurus for guiding and inspiring us to be on the right path and making us what we are today. With this short prayer, I welcome you all to the much awaited event on Vonoprazan, first in class PCAB for acid related diseases. Hetero Healthcare is an innovative pharmaceutical company since more than 3 decades, which caters to around 14 plus therapeutic groups aiming to improve patients' quality of life. Hetero was majorly involved in tackling the national emergencies such as swine flu in 2005 and COVID-19 epidemic with the drugs such as remdesivir, favipiravir, and nirmatrelvir. This was possible only due to strong R&D facilities and state-of-art manufacturing facilities that have ensured the seamless supply of medicines. As a solution provider, we always believe that manufacturing of newer medicines are an integral part of uplifting human life. Currently available proton pump inhibitors represent the mainstay of the management of acid-related diseases such as GERD, peptic ulcer disease, and H. pylori infection. However, around 50% of GERD patients have reported an inadequate response to the conventional PPIs due to several unmet needs. It was essential to develop a novel drug to improve the clinical outcomes of such acid-related diseases. Hetero has again established its role in bringing newer solutions for the first time in India with Vonoprazan in managing acid-related diseases. Vonoprazan, the first-in-class potassium-competitive acid blocker, has been approved for GERD, reflux esophagitis, peptic ulcer disease, and H. pylori infection in Japan in 2015. It was then approved in 2019 in China, and then US FDA has also approved Vonoprazan in 2023. Vonoprazan has shown several unique advantages over PPIs, such as rapid onset of action without requiring acid activation, full effect from the very first dose, more potent and prolonged inhibition for over 24 hours, including a better nighttime acid control, meal-independent anti-secretory activity, and favorable safety and tolerability profile in long-term clinical studies. As we know that non-steroidal anti-inflammatory drugs are commonly prescribed to manage pain and inflammatory symptoms in patients with rheumatoid arthritis and osteoarthritis, but they can cause GI mucosal injury and bleeding, which can lead to ulceration. Vonoprazan has established efficacy and safety for long-term use in the prevention of NSAID-associated peptic ulcer disease in high-risk patients. There are also studies which have confirmed the Vonoprazan use as a potentially effective treatment for systemic sclerosis-associated gastroesophageal reflux disease. All these patients with rheumatological diseases are on multiple medications, which can lead to severe acidity-related symptoms. PPIs are commonly prescribed along with other drugs such as NSAIDs, DMARDs, and other anti-inflammatory drugs. However, they need to be taken, the PPIs need to be taken on empty stomach for almost like 30 minutes before the food. Vonoprazan, unlike PPIs, can be taken before or after food, and most of the doctors have coined Vonoprazan as 11 a.m. drug, which can be taken after breakfast along with the other prescribed medications. To discuss this potential role of Vonoprazan in managing acid-related diseases, I would like to invite our first, the chairperson for the webinar, one of the eminent and senior consultant, Dr. Rohini Handa, sir. He's currently working as a senior consultant rheumatologist at Indraprastha Apollo Hospitals, New Delhi. He has 40 plus years of rich experience in the field of rheumatology and has several leadership positions, such as Distinguished Clinical Tutor at Apollo Hospitals, Educational and Research Foundation, Honorary Consultant in Rheumatology to the Armed Forces Medical Services, Dean of the Indian College of Physicians, President of Asia Pacific League of Associations for Rheumatology, Chair of International League of Associations for Rheumatology, President of Indian Rheumatological Association, President of Delhi Rheumatological Association. He has several prime awards on his name, such as Indian Council of Medical Research, M.N. Sen Oration Award, and Shakuntala Amir Chand Prize, the Indian Rheumatology Association Dr. M.N. Pessi Lifetime Achievement Award, and IRA Master IRA Oration, the Association of Physicians of India Master Teacher Award, Indian College of Physician and Association of Physician of India 2022, Netaji Oration, Searle Oration, J.C. Patel and B.C. Mehta Prize, Pavan Kumari Jain Oration, and Dr. G.N. Berry Award. The Indian Academy of Clinical Medicine, Dr. G.B. Jain Oration, and Dr. Sukumar Mukherjee Honor Lecture. He has been also awarded as Distinguished Academician Award by the Apollo Hospital in 2018. Dr. I.A. Modi Award for Distinguished Clinician in 2021 by Global Association of Physicians of Indian Origin. Dr. Handa has also published 350 plus review articles, book chapters, papers, and abstracts. He is also the author of immensely popular book, Clinical Rheumatology. We welcome you, Dr. Handa, sir. With this, I would like to hand over the session to Dr. Handa and request him to introduce the speaker of the webinar. Over to you, sir. I sincerely thank everyone for joining us this Sunday evening. Thank you all. Thank you.
Thank you very much for this rather generous introduction. And let me take this opportunity to welcome all attendees and the lead speaker of the day, Professor Anil Arora. Now, this webinar is focusing on a first-in-class introduction, Vonoprazan, which is a potassium competitive acid blocker. Speaking to us today is none other than Anil Arora, who heads the Department of Liver, Gastroenterology, and Pancreatobiliary Sciences at Sir Gangaram Hospital. He's an accomplished gastroenterologist, several awards to his credit, and he heads the third space endoscopy program at Sir Gangaram Hospital, has been instrumental in several workshops imparting hands-on training to people from the subcontinent. He's been one of the main architects in formalizing Indian guidelines for Hep B, immunosuppression and hepatitis B, anticoagulants and antiplatelet agents in patients with GI bleed, and many others. He's an alumnus of the All India Institute of Medical Sciences, very well known in rheumatology, gastroenterology, and indeed all medical circles. Without further ado, can I request Professor Arora to speak to us about Vonoprazan? Over to you, Anil.
Thank you, Dr. Rohini. At the outset, I'm extremely grateful to the Indian Rheumatological Association, ably headed by you, and the team Hetero for giving me this opportunity. Am I allowed to share my slides?
Yes, sir.
Are the slides visible now?
Yes, sir, they are visible.
The topic which I'm going to discuss today evening is current and the future strategies for acid suppression. So what I'm just going to talk to you about is the total acid peptic disease burden in India, the reasons why we need to suppress the acidity and for different medical illnesses. Do we still need to have more and more acid suppressants, especially with availability of state-of-the-art PPIs which are available around the market? What is the need of discussing on this Sunday evening the new upcoming molecule called PCAB or potassium competitive acid blocker? What is the clinical efficacy and evidence of the relevance of the PPI in subgroup of the patients requiring acid suppression? And finally, Are these newer drugs called PCAB, have they been recommended by any guidelines so far? The answer to the first question, that are we discussing the topic which has some relevance today, is the problem as common that we should be discussing on the eve of this Sunday evening? The answer is a big yes. If you look at the burden of acid peptic disease in India, it is not only important, but it is humongous all over the world. If you look at the geographical map of the acid peptic burden in the world, you'll be surprised to know that between 1990 and 2019, the incidence, prevalence, and the lives lived with this disability due to the acid peptic disease have increased by almost 75%. If you look at the overall prevalence of the peptic ulcer disease across the world, it's quite variable between less than 10% in some areas to more than 25% in different geographical regions. Overall, every fourth individual in the world, and if you go by enormity of the world population, which is to the tune of about 8 billion, say about 2 billion people would complain of problems related to the acid peptic disease. Not only is the problem common all over the world, but if you look at the prevalence of acid peptic disease in India, it has gone on increasing trend from 1990 to the last published data in 2017. The disease is almost double in its prevalence. And if you look at the prevalence of the reflux esophagitis, something which is debilitating in day-to-day basis, 15% of the population in India, if you go by our own Indian population of 1.44 billion, you can imagine 1/4 of our population suffers from gastroesophageal reflux disease. Helicobacter pylori is one of the important reasons for causation of the peptic ulcer disease. Dr. Rohini would agree with me that we were doing our DM together at AIIMS, we were knowing of only one thing which will cause peptic ulcer, that is acid. And there used to be a conundrum called no acid, no ulcer. But for the first time, an intern in Australia with his mentor on possibly Guru Purnima Day discovered this new agent called Helicobacter pylori. This is the agent which is a partly aerophilic bacteria, gram-positive bacteria, which tends to reside in the antrum of the stomach and tends to make merry by trying to have harmony between the epithelium and the acidic mucosa, and tends to stay in the upper layers of the epithelium in the antrum and the body of the stomach. In fact, this has been touted to be the most important cause of peptic ulcer disease. And the patients who are not taking NSAIDs, it is said 90% of the peptic ulcer tends to occur because of the Helicobacter pylori. For the first time during our MD days, and when we were planning to do our gastroenterology training, we were told that acid alone is not the culprit for peptic ulcer disease. In fact, Helicobacter pylori was one of the important infectious causes of peptic ulcer disease, which can be easily taken care of. In the normal course of the events, once you ingest the infected water with food or contaminated food or the water, you have an acute infection, which typically tends to get chronically established in the GI tract, especially in the antrum of the stomach or in the different parts of the stomach, whether it is in the antrum or the body of the stomach, leading to number of complications characterized by a duodenal ulcer, or it can cause also gastric ulcers and metaplasia, at times related to development of gastric ulcer and gastric cancer. In fact, WHO, 10 years after the discovery of this agent and the microbiological agent in 1982, had characterized this as a class 1 WHO, class 1 carcinogen. In patients who have acidity in the stomach, acidity is meant to protect us for different reasons. You see, if you do not have acid in the stomach, so anything which you are getting, which you are ingesting by default will have a lot of bacteria passing down into the intestinal tract, which can cause misery to the GI tract for the purpose of absorption and causing infection. So you have aggressive factors as well as the defensive factors which will prevent the mucosal lining of the stomach in prevention of peptic ulcer formation. So by default, the stomach tends to produce mucus, bicarbonate, as well as the prostaglandins. Whereas you have aggressive factors like Helicobacter pylori, use of NSAIDs, pepsin, and the smoking, which will tend to injure the mucosa. So it is an imbalance between the two, which leads to formation of a peptic ulcer disease. So if you have too much of the gastric acidity, which occurs because of the use of NSAIDs, oxidative stress, and the persistent and the continuation of the H. pylori infection, you tend to have less protective factors, which lead to an imbalance of aggressive and protective factors, resulting in the formation of the peptic ulcer and the peptic ulcer disease. In fact, if you go back to the history of the peptic ulcer disease, let us salute this man called Dr. Karl Schwartz. So way back in 1917, he thought of this, he gave this paraphrasing of no acid, no ulcer, which is relevant even today, even about almost 100 years after he had proposed this, after he had paraphrased this new nomenclature of acidity causing ulceration in the stomach. And even after about 100 years of his paraphrasing this new concept of acid and ulcer, we are still looking for newer and newer drugs to cause suppression of the acidity that will cause prevention of the peptic ulcer in the patient with the peptic ulcer disease. So way back in 1930s, antacids were discovered. In 1970s, H2 receptor antagonists like ranitidine, famotidine, nizatidine were discovered. Again, Dr. Rohini will recall that in 1980s, one drug was introduced in the market in the form of omeprazole. The drug was such a potent suppressant of acidity that people were worried that if you are completely neutralizing the acidity in the stomach, your GI tract will be exposed to the humongous number of bacteria and the microorganisms causing havoc. In fact, there were some published reports of potent suppression of acidity because of the omeprazole and resultant increase in the enterochromaffin-like tumors in the rats. And hence, for 10 years, next 10 years, the drug was withdrawn because it was such a potent drug. It will reflexively increase the size number of enterochromaffin cells, resulting in so-called gastrinomas in rat. But subsequently, it was seen that this development of enterochromaffin tumors or gastrinomas was a specific problem of only rats. There were no human reports of use of PPIs causing gastrinomas, and hence drug was reintroduced in the market in 1980 with bang. And since then, it has been ruling the roast. If you see, ever since 1988, when omeprazole had come back into the market, over the next almost 30 years, PPIs have ruled the roost. They are the most selling drugs in the market and have had a wonderful response in terms of suppression of the acidity. Why is it that still we are looking for a better drug? Let me get back to the basics of acid production in the body. In the normal course of the events, this is the body of the stomach. It is typically divided into the two parts. You have the gastrin producing area and you have the oxantic mucosa. Now, these are the two parts of the stomach which are important for causation of the acidity as well as the formation of the ulcer. As I had already said, the H. pylori tends to be present in the antrum of the stomach. If you see in detail the oxantic mucosa, you have these multiple gastric pits which are lined by the gastric glands. Gastric glands tend to produce small amount of the thin mucus which tends to go into the gastric pits and then goes into the gastric lumen. Now, what happens in patients in the routine course of the events is that this gastric pits are also lined by the mucal cells which line the gastric pit at the entrance of at the proximal part of the gastric pits. This is the lumen of the intestine and that is the distal part of the intestine, that is towards the serosa. So this mucus cells produce and secrete thin and watery mucus. You have parietal cells, which are the cells which will secrete the hydrochloric acid as well as the intrinsic factor, which is so important for absorption of the vitamin B12. In addition, you have the chief cell, and chief cells by default will produce this enzymes called pepsinogen, which in the gastric juice, which is a thickish component of the gastric juice. In addition, the gastric glands also have the stem cells, which have a propensity not only to regenerate the degenerating gastric mucosal epithelium, but also it also tends to migrate to the surface, getting into either the surface epithelium cell, or it even tends to replace the dying and degenerating parietal cells. So this is the reserve cells which is trying to regenerate the gastric mucosa, which is known to be replaced on every third day. It's important to understand that the lining of the gastric pits as well as the gastric epithelium gets replaced every 3 days because it is bathed in the harsh, realistic part of the acidity which is present in the stomach. The surface epithelium cells also tend to secrete a thick mucus. So what happens in patients in the normal course of the events, you have pepsinogen which tends to come into the circulation through the pits. So it is the gastric epithelial pits which tends to block the passage of the pepsinogen into the lumen. In addition, the parietal cell has a peculiar ability to produce acid. The water in the parietal cell is split into the hydrogen and hydroxyl ions. Hydrogen ion moves out into the lumen of the stomach. As one positive ion goes in, there is a movement of the potassium, another positively charged ion into the lumen of the stomach, but then it does not stay into the stomach and quickly moves out, thereby having a preferential negativity charged internal lumen of the parietal cells. The hydroxyl ion, which is present in the stomach, which has been split from the water, then is acted upon by the enzyme called carbonic hydrase to produce sodium bicarbonate. This bicarbonate is then split into, then gets attached with carbon dioxide, and the CO2 which is produced, it moves out as bicarbonates into the circulation. As this negatively charged bicarbonate is moving out into the circulation, there is a movement of the chloride ion, which is negatively charged into the parietal lumen. Now, this is a movement which is against in flow with the electrochemical gradient. It is against the electrochemical gradient because the chloride is not high in the lumen of the blood vessel supplying the stomach, whereas in the lumen of the parietal cells you have less chloride. As the chloride concentration increases in the parietal cell, so with the concentration higher gradient, part of the chloride ion moves out. Now see what is happening is hydrogen is moving into the parietal cell, and then potassium is getting out. As the hydrogen is being pushed out, chloride ions also get pushed out into the lumen of the stomach. So at the end of the day, you have hydrogen chloride, which is being produced on regular basis inside the stomach. So this is how the gastric parietal cell on regular basis produces the hydrochloric acid. So when we have a drug which completely suppresses the acidity in the stomach called proton pump inhibitor, so why is it that we are looking for newer drugs like PCAB or potassium acid blocking agent? But it has been recently shown that even when we were rejoicing the success of the PPIs in treatment of peptic ulcer disease, we did realize that 2/3 of the patients with reflux esophagitis, which mind you is prevalent in about 20% of the Indian population, is still not satisfied with the relief in the symptoms. And 50% of these patients continue to experience symptoms even with maximum dose which is given for a period of about 2 to 3 days. In addition, there are other unmet needs of the currently available PPIs like omeprazole, rabeprazole, pantoprazole, lansoprazole, lansoprazole, dexlansoprazole, etc. Because these drugs are not useful because patients are not able to adhere to the drug properly. They do not suppress the acidity completely. You still have residual acidity, and unfortunately, they have a weak suppression of acid, especially in the evening and in the late night. So we do have to look for alternative therapies for treating reflux esophagitis. In addition, the treatment of Helicobacter pylori, which is the chief culprit for causation of peptic ulcer disease, is not adequate as of now, both because of the lack of efficacy of the currently available PPIs, as well as the resistance to the antibiotics which are given as a part and parcel of therapy for Helicobacter pylori treatment. In fact, there have been studies which have shown that if you see the patient with severe reflux esophagitis, as many as 40% of the patients will have incomplete relief of the symptom, which is related to the incomplete suppression of the acidity when you are using the top of the line PPI for esomeprazole or lansoprazole. In addition, the response is inadequate in about 20 to 40% of the patient. Biggest problem with PPI is that it is a prodrug. It is a drug which is acid labile. What it means is once it goes into the stomach, it will be quickly degraded, and hence it has to be given as an enteric-coated tablet. From the stomach, the drug goes into the small bowel. From there, it is absorbed into the circulation, and from circulation, it again comes back to the proton pump areas, that is the areas of the parietal cell, which I showed you earlier, and then gets into the parietal cell for blocking the proton pump. These drugs are typically metabolized by the cytochrome P450 C219. CYP2C19 is the cytochrome which will metabolize these drugs. And I'll give you an example of how so many other conventionally used medications are also metabolized by this group of the cytochrome P450 system. So the drugs can either become too overactive or too underactive to give you the pharmaceutical benefit. In addition, PPI also tend to fail the night side suppression, and they cannot be given on full stomach. The biggest advantage of the PCABs is that it also acts on so-called inactive pump, which I'll explain. So overall, over the last 40 years, ever since in 1988, when omeprazole launched into the market, we as gastroenterologists or you as rheumatologists have been shuffling only between different types of PPI to give our gullible patients the ways and means of suppressing the acidity. Now, again, coming back to the how the acid is typically produced. So this is the parietal cell, which I had explained you how it produces acidity. There are three incoming stimuli to the acid production. You have the gastrin, which is released from the G cells of the stomach. This gastrin also stimulates the enterochromaffin cells, which produces histamine, which goes and stimulates the parietal cells through the histamine receptor. And then you have the cephalic phase of acid production, which through its release of acetylcholine, using the acetylcholine receptors, increases the calcium, which stimulates the hydrogen potassium ATPase pump. This is the pump which I had explained you, which puts the hydrogen out and potassium in to produce the acid in the lumen of the stomach. So PPIs will tend to block hydrogen potassium ATPase. If this is the reason, why is it not that every cell which is blocked will never produce acid? The difference between the currently available PCAB and the currently available PPI is that PPI will lead to a non-covalent binding with the hydrogen potassium pump. What this means is once PPI gets attached to this pump, it's not going to leave this pump till the cell is dead into the stool. Second problem with PPI is that it is going to act only on the PPIs which have been activated by the meals. So once the meal is given to the human being, 40% of the proton pumps get activated. Rest of them are lying dormant in the body of the cytoplasm of the parietal cells. So not all proton pumps which produce acidity are active at given point of time. PPIs will only block the hydrogen potassium pumps which are actively present on the surface of the epithelial cells. Now coming on to the new class of drug, let's see what it does. You have the three same stimuli, the gastrin, the histamine, and the acetylcholine through the cholecystokinin, histamine, and acetylcholine receptors are trying to stimulate the parietal cells to produce the acidity. Now, as they are increasing the calcium in the parietal cells, they'll go and attach to the hydrogen potassium ATPase. Now, the difference between PPIs and the PCABs is the PCABs are not blocking this pump. It is selectively acting only on the hydrogen, only on the potassium channel. It is sparing the total pump. That is a basic difference between the two. So this is a PPI, and then the PCAB will be acting only on this channel, will not be acting on the total pump. So in patients who are using PPIs, you are only inactivating the active pumps which are producing acidity, and hence these drugs will not neutralize the inactive pump. They have to be given fasting because they cannot be metabolized because they get degraded in the stomach. They have a slow onset of action. They have limited potency. So we had this discovery of a new drug. In fact, in the last 30 years, this is the most potent drugs which has been discovered for the use by the human being, especially the gastroenterologist. This drug was discovered and launched for clinical utility in 2015 after being discovered in 2007 in Japan. Since Japan is not at the top of the medical discovery, especially when you compare it with US, so the Japanese had to convince the US authorities over the last 8 years to tell us about the efficacy and utility of this molecule. So this new class of drug called Vonoprazan is a drug which is a potassium channel acid blocker. It was discovered in 2007, was marketed in 2015 in Japan. It took US FDA another 8 years to realize its utility in suppression of the acidity. And you'll be glad to know that DCGI in India has approved its use in patients with peptic ulcer disease only about 2 months back. Now, the basic difference between the two is that, as I said, that PPIs get degraded in the stomach and hence have to go out into the small bowel, get absorbed and get back into the circulation. Biggest advantage of Vonoprazan that it is an acid labile drug. That means as soon as you take the tablet, goes into the stomach, it directly goes into the gastric pit and gets attached to the potassium channel. It does not block the pump, it only blocks the potassium channel. So unlike PPI, which are acid labile drugs and has to be given as enteric coated tablet, this drug can be given on full stomach. That is the biggest advantage. One of the reasons why people are not compliant with medication is that they tend to forget that they have to take the drug in the fasting state. So as Dr. Halal very rightly said, this is the 11 a.m. drug. So irrespective of the timing of the meal, you can take this drug at the same time. Another biggest advantage of this drug called PCAB is that it also tends to block the inactive proton pumps which are lying dormant in the parietal cell. Suppose the parietal cell, there are 100 proton pumps which will produce acidity in a parietal cells, of which 40% become active because of the stimulation by meals. 60% still remain dormant, they are not in use. PPIs will only block selectively the pumps which have been stimulated by the meals, whereas the PCABs or the potassium channel acid blockers will go and block even the resting PPIs and hence will give better suppression of the acidity as compared to the conventionally available PPI. So this is what happens, ladies and gentlemen. Again, coming to the basic cycle of acid production. As I said, there are 3 mechanisms by which the acids get stimulated. You will have, I've already informed you about the parietal cell being stimulated by the histamine, acetylcholine, and cholecystokinin. Now, as against the PCABs, as against the PPIs which were blocking the acid hydrogen potassium pump, PCABs are only blocking the potassium channel, thereby sparing the pump in general, thereby causing significant change in the acid production, as they also tend to block the inactive pump. So the advantage of Vonoprazan over other conventionally available PPIs are that it is stable in the acidic media, it binds with a slow dissolution rate, it has a longer half-life of 7 hours because it does not have to go to the blood and in the liver for metabolism before it acts back onto the stomach. It has a rapid onset of action. It has a durable action for production of the acidity and suppression of the acidity. And this is the basic difference between the two. It quickly suppresses the acidity completely within a period of 1 day compared to the conventional 3 to 5 days. Its half-life is 7 to 9 hours compared to only 2 hours of the PPI. The reason for a low half-life of PPI is that part of it is degraded by the CYP450, whereas the Vonoprazan has to directly act into the stomach onto the proton pump. It does not have to go to the circulation to act on the proton pumps. The duration of the effect is much longer with Vonoprazan as compared to the PPI, since it does not have a interaction with the CYP2C19 type of mitochondrial enzymatic degradation, so it has less interaction with other molecules. It acts also on both active and inactive proton pumps, whereas for PPI, you need to have active pumps which need to be try to suppress their activity. It has the vonoprazan has no influence on the meal and hence can be given any time of the day, whereas PPIs have to be given before meal because they are acid labile drugs. This drug has been directly acting. It does not need to be a pro-drug which needs to be converted into active moiety before acting onto the stomach. And the concentration of the concentration in parietal cells is 1 lakh higher than the plasma cell, whereas in patients who are using PPIs, only 1,000 is the concentration limit of PPIs in the parietal cells. So overall, on 1-to-1 basis also, this drug is more likely to be potent. So how does this vonoprazan compare to the other conventionally available proton pump inhibitor? It gives you a higher pH holding time. It has a longer pH as compared to the conventional PPI. It gives you better suppression of the nocturnal acidity. It gives you better healing rate in both reflux esophagitis, peptic ulcer disease as compared to the conventional PPIs. And if you look at the eradication rate of Helicobacter pylori, it scores far higher than the conventional PPIs. In fact, the conventional PPI will give you a cure rate of only about 80% for treatment of Helicobacter pylori. And recent network analysis from the Japan has clearly shown that if you use a vonoprazan-based PPIs for eradication of Helicobacter pylori, which involves the use of PPI coupled with 2 antibiotics, then your success rate for eradication of H. pylori goes to the tune of about 90%. Is there any flip side to the use of the PPI which have been in the market and ruling the roost for almost 40 years? There have been studies recently, I'm sure as seasoned clinicians, you would have realized that there have been multiple reports, especially in the journal called Lancet, of increased risk of fractures, increased risk of renal injury, osteoporosis, and the repeated infections related to the overuse of PPIs in the general practice. In fact, this is the subgroup of the patient in which long-term use is appropriate. If you have a Barrett's esophagus, that means a persistent reflux esophagitis, which is of severe variety. You have eosinophilic esophagitis. You have so many of you in your clinical rheumatology practice must be seeing these disorders of hypereosinophilic syndromes. You have idiopathic peptic ulcer disease, Zollinger-Ellison syndrome, recurrent reflux esophagitis, long-term use of non-selective NSAIDs, for long-term use of antiplatelet agent, and the steatorrhea, which is refractory to enzyme replacement therapy in chronic pancreatitis. These are the established uses of long-term PPIs, whereas short-term PPIs are indicated in patients who are taking H. pylori, who have non-specific peptic ulcer disease, who also have a history of bleeding related to the peptic ulcer, or those who have been on prophylaxis for stress ulcer bleeding. But then as we realize that these are the potent suppressants of acidity, we should not try to misuse PPIs. And hence, PPI used on long-term basis is not appropriate in patients who are using steroids alone without concomitant NSAID therapy. This is not used in patients who are bleeding from hypertensive gastropathy in cirrhosis of the liver. Patients with acute pancreatitis or stress ulcer prophylaxis do not need long-term use of the PPIs. Is there any evidence of the efficacy of this new PCAB called vonoprazan over and above the conventional PPIs? I'm sure most of you as seasoned clinicians would be realizing that over a period of time, as Dr. Carl Schwartz said, that no ulcer, no acidity, that particular paraphrase is still ingrained in our mind. And even today, we are using and looking for more and more measures to suppress the acidity. We discovered antacid in 1930, H2 receptor in 78, PPIs in 1980, and then 40 years later, we discovered this new drug called PCAB or vonoprazan. Why is it that, especially when we were going to play the World Cup T20 tournament, we had a star study team ably led by Rohit Sharma. We had big bigs like Rohit Sharma and Virat Kohli. Why is it that we still had to bank upon our younger brigade led by Yashasvi Jaiswal, Rinku Singh, Sarfaraz Khan, or even Surya Kumar Yadav. Because now we realize that if Surya Kumar Yadav wouldn't have taken that fumbling catch at the boundary, that mesmerizing one-handed catch in the boundary by jumping across the road and coming back into the boundary to complete the catch, I don't think we would have been able to win the match. So we have to have something which is extraordinary, and that extraordinary possibly is the drug called Vonoprazan. It has also been known that reflux not only causes acidity in the stomach. Our ENT colleagues have really made us aware of the fact that the patient who have repeated nocturnal cough, have hoarseness of the voice, and may also be having the need for PPIs to suppress their acidity. In fact, drug-drug interaction is so important because the drugs which get metabolized through CP450 have been really good. So is it that I'd like to know from Rohini, that is it, Dr. Rohini, curtain down for PPI? Is it the end of the PPIs that we should only be using drugs like PCAB? But we should also at the same time realize the good, bad, and the ugly side of the PPIs. There is no doubt that these are potent acid suppressants, but we also realize that drugs like PPI will also have drug-to-drug interaction, especially if you talk of drugs like dilantin or drug like clopidogrel, which has to be met. These are the two classical examples in which the CYP2C19 is important for their metabolism. So if you are taking a drug, say like omeprazole or pantoprazole, in addition to dilantin or hydroxyzine, so this is the drug which will cause competitive inhibition of the metabolism, and hence the dilantin will not be metabolized properly, leading to occurrence of the toxicity of the dilantin. Since clopidogrel is a drug which needs to be converted into active moiety, if you are using it with pantoprazole, clopidogrel will not be converted into active moiety and hence will not have its true antiplatelet effect. In fact, there have been case reports of coronary artery thrombosis occurring in patients who are using clopidogrel as an antiplatelet agent in concurrent use with PPIs. And all of us also know the ugly side of use of the PPI in the form of renal impairment, osteoporosis, and fractures. So long-term PPI therapy is associated with large number of side effects which have been mentioned over here: chronic kidney disease and pneumonia, repeated infection, osteoporosis, hypocalcemia, osteopenia, etc. In fact, there have been some reports of occurrence of the CKDs and the interstitial nephritis related to the injudicious use of PPIs. And because we are suppressing the acidity to almost nil levels with the currently available PCABs and PPIs, you are likely to have more bacteria bypassing the protective stomach and go into the small intestine, producing number of enteric infections, including Clostridium difficile and the small intestinal bacterial overgrowth syndrome. The PPIs also have tend to hinder the absorption of the calcium from the stomach, which is absorbed in the proximal duodenum, and hence are likely to cause osteoporosis of the stomach. So that much about the good part of it, that we know that they are useful in large number of the patients who have reflux esophagitis, who need suppression of the acidity in form of recurrent peptic ulcer disease, or patients who are using long-term NSAIDs for their condition. But the bad part of it is that, like in India, these drugs are also available off-counter in the Western world, and their use have been increasing over a period of time. If you see over the last 30 years, there has been almost doubling in the use of PPIs over a period of time, and the PPIs are increasing in its availability across the board. So that is where we need to remember the bad part of it, that the side effects of the PPIs are important to remember. I showed you the definite indications of use, and I also showed you the indications where it should not be used on long-term basis. The ugly side of the PPI has been repeatedly highlighted by the publication in all journals. It is known to be associated with kidney disease, osteoporosis, and repeated GI tract infection. So the ugly part of the suppression of the PPI, if it is well ingrained in our mind, I'm sure most of us as gastroenterologists and rheumatologists will be using PPIs and the PCAB on a judicious basis, as I have already mentioned. So what is the best practice advice from the AGA? AGA, after analyzing all the data of the good, bad, and the ugly at the PPI, has clearly said that long-term PPI should not routinely require probiotics to replace the useful bacteria. In fact, even long-term with the use of the PPI does not hamper the absorption of the vitamin B12 as well as the vitamin and the calcium. And this is the vision trial published on the long-term safety and the efficacy of the vonoprazan over a period of 3 years in patients who have been taking NSAIDs for various rheumatological indications. And in this subgroup of the patient, there was no evidence of enterochromaffin-like hyperplasia in the stomach, neither in the clinical scenario nor in the histopathology of the biopsy obtained from the gastric mucosa. And these drugs were presumed to be pretty safe. So till date, on long-term use of vonoprazan for as long as 7 years, there have been no side effects on either the intestinal metaplasia or on the development of the SIBO and the osteoporosis. In fact, another 12-month post-marketing surveillance study on vonoprazan has also established its efficacy. That drug is very well tolerated. It causes suppression of peptic ulcer recurrence to only 1%. Mind you, if you are using long-term NSAIDs and if you have a concomitant use of vonoprazan, the chance of ulcer relapse is practically 1% only. That is the biggest advantage. And meta-analysis has also shown that it has an excellent long and the short-term safety, so far as you remember that it has to be used judicially. In fact, this is the 3 years data of 12-month post-marketing surveillance published from Japan, in which it has shown that long-term use of vonoprazan in patients who are using NSAIDs on long-term basis is safe and efficacious. So do the guidelines recommend it? Yes. Japanese guidelines of gastroenterology do recommend vonoprazan as a drug of choice for treatment of both peptic ulcer as well as for patients who are having reflux esophagitis. Even in AGA practice guidelines, American Gastroenterology Association Clinical Practice Guideline and Maastricht Fluorescence Consensus Guideline, vonoprazan is not inferior to the drugs, and in fact, because of its potency, is touted to be one of the drugs which is going to be available for us in day-to-day practice very soon. So as of now, the indications of using this potent suppressants of acidity includes certainly the patient with moderate and severe reflux esophagitis, patients who need treatment for peptic ulcer disease as both duodenal and the gastric ulcer, patients who are requiring long-term use of aspirin and clopidogrel for prevention of recurrence of thrombosis in the coronary artery disease, large number of the patients who require NSAID for rheumatological condition and have history of peptic ulcer disease or complications related to the peptic ulcer disease. And certainly it is the drug of choice to eradicate H. pylori infection, which is thought to be the cause of peptic ulcer disease in about 90% of the patients. So the dose which is recommended for treatments of various acid-related diseases include 20 milligram dose per day for a period of 6 to 8 weeks if you have a peptic ulcer disease. But if you are using it only for maintenance or prevention of the disease, you have to come down to 10 milligram per day. It is only in H. pylori that you have to use dual therapy. So the biggest advantage is single dose therapy on daily basis for treatment, 10 milligram per day therapy for maintenance, and double dose therapy for peptic ulcer disease. One has to be careful since the drug has been in the market only for about 10 years. You have to be really careful when you're trying to switch over from PPI to PCAB, especially in the patients who are in the elderly age group, in the pediatric population, and the pregnant women. In fact, there are hardly any contraindications, only few allergic cases of reaction secondary to idiopathic synchronous allergy to vonoprazan has been reported. Otherwise, drug is supposed to be pretty safe. To summarize, ladies and gentlemen, we have heralding of a new class of drugs called PPI, which have been the revolutionary drug. I think this is one of the best drugs known to a practicing gastroenterologist for management of the peptic ulcer disease. So far as we understand its efficacy and advantages over and above the conventionally available PPIs, And so far as we also understand the ugly side of it, I think a judicious use of this drug is going to be a welcome relief for us. With that, I'll hand it over back to Professor Handa for taking it forward.
Thank you very much, Dr. Arora, for a very elegant exposition. I thoroughly enjoyed your exposition, and I think multidisciplinary meetings, there is so much of learning. As a rheumatologist, we use anti-inflammatory drugs right, left, and center. But it was a pleasure to listen to you. And we will now take up questions and answers. And I would request the viewers to please type in their questions in the chat box. And well, we have some questions coming in. And I would like at this point to start by asking you, you see some old clinicians writing with steroids, 30 ml of Digene. Do you think this is a practice rooted in science, that whenever they write steroids, they write antacids to everyone in the morning? And you still find these prescriptions coming. As a gastroenterologist, how would you respond to this?
Yeah, I think I agree. This is a practice which has been going over the ages. But if we understand the science behind the utility of antacids, they were discovered after that phrase by Karl Ford that no acid, no ulcer, that antacids are the drug which will give you immediate symptomatic relief in case you have burning in the stomach. So if you have hyperacidity, if you have a drug-induced gastritis, if it is related to the acidity, you give an antacid preparation which is locally available. So whatever we have discussed till now, be it PPIs or PCAB, they will suppress the acidity which is going to be found by the PPI. What antacids do is they'll immediately douse the fire which is available. They will only give you symptomatic relief. If you have no symptom, there is absolutely, I fully agree with you, absolutely no justification of routinely adding steroid. That is a practice which needs to be condemned. Because only if you have symptoms, you will have relief. It does not change the under pathological mechanisms of injury.
I think very, very well put. And you made one very important point that, with steroids, prophylactic use should not be advocated. There was within the fine print where you made it very clear that routine use with steroids should not be recommended. Now, there is a question. Can Vonoprazan be given along with prokinetics?
Yeah, you see, vonoprazan and prokinetics have different actions. They are not competitors. They are not like Yashasvi Jaiswal and Rinku Singh vying for the opener slot in Indian team. Vonoprazan suppresses the acidity. It has clear-cut, well-defined indication, which are stated very clear. Peptic ulcer disease, H. pylori infection, hyperacidity states, or long-term use of NSAID. Prokinetic drugs are the drugs which are going to propel the musculature of the stomach towards the caudal end. They increase the motility of the stomach. If you have postprandial abdominal fullness, if you have postprandial abdominal heaviness, or if you feel bloated after the ingestion of the food, prokinetic drug will try to increase the motility of the stomach and will move the gastric content from the antrum into the duodenum. They have nothing to do with the acidity. So it is basically for increasing the gastric motility, and they do not cause anything to suppression of the acidity. In fact, it is used in patients who still continue to have bloating in peptic ulcer disease even after use of PPIs. Otherwise, in the routine suppression of the acidity, even in patients with peptic ulcer disease, if the patient does not complain of bloating, there's no need of adding drugs like prokinetics. I'm sure he must be referring to the combination of the drug like Pan-D or Vilozil or Pan-L or Pentosid-L, in which a prokinetic is always pegging back on a PPI. So that does not give you an advantage. Scientifically, it has no advantage.
Then we have another question on vonoprazan along with antiplatelet therapy. Can the two be given?
Yeah, as I said, in fact, Dr. Rohini, you would remember that there is a lot of hue and cry recently about the drug interaction between clopidogrel especially and the P450 mechanism. Because, as I said, PPI is like pantoprazole, They are acid-labile drugs. So they are prodrugs. They get absorbed into the intestine. From there, they go into the circulation, get degraded in the stomach through this CYP2C19 mechanism. Now, clopidogrel, which is another antiplatelet agent, is also getting degraded through that. Clopidogrel is also a prodrug. For it to have an antiplatelet action, it has to be activated. So if there is one slot available on CYP2C19 and both drugs are competing, and if you are taking PPIs at the same time, then clopidogrel does not get activated and hence does not have antiplatelet action. So there has been one school of thought that you should separate out the ingestion of the two. Pantoprazole you can take in the morning and clopidogrel in the evening or vice versa. But nowadays with the availability of Vonoprazan, that complexity is gone. Since this is not metabolized by CYP2C19, so there is no interaction, you can safely take it with clopidogrel.
Okay, so the answer is yes. And then we have long-term safety. You have mentioned it. Can you iterate it again for the benefit of people? Long-term safety of Vonoprazan.
See, Vonoprazan and PPI, if you see on one-to-one basis, are both of them are causing suppression of the acidity. In fact, Dr. Oni would agree that you people have a huge rheumatology practice, and I'm sure most of you on long-term anesthetics are coupling it with PPI. So you will have a 20 years experience of using PPIs for acid suppression. And in my own practice of almost about 35 years in gastroenterology, I have not seen any side effect which I can pinpoint to use of PPIs. In fact, the data which has been published is possibly skewed data on epidemiological basis. There is no cause and effect relationship with the PPI and the side effects. And that is the reason if you see the recent recommendation of American Gastroenterology Association, they do not believe that PPI do cause long-term side effects. So Vonoprazan is something which has been available in the market for 7 years in Japan and for 2 years in US and for a few months in India. But if you go by the safety profile on long-term basis in Japan, it is a pretty safe drug. So far as we use it judicially. Again, Dr. Rohini, I'll reiterate that unless it is needed, there is no point of just for the heck of adding a drug to suppress non-ulcer dyspepsia, we should not be using PPIs.
I think this is very, very important that, indiscriminate use, and thank you very much for emphasizing this. And then there's a question about side effect profile of this medicine, and do you need lab monitoring?
Yeah, you see, this is, as I said, this is a drug which has been in the market. It has been in use in Japan since 2015. And, as US certainly will not believe the Asian scientists when they come up with a new molecule. So it took them about 8 years to look at the utility of this new molecule. In general, since the long-term safety has not been shown to be bad for this drug, and it has been shown to be efficacious and safety, there is no indication for monitoring this drug. In general, most of the antacid preparation do not require monitoring. If you are suspecting a side effect, better switch the molecule and change over. There is no way to monitor the drug.
I think it's very, very clear that you do not need routine laboratory monitoring. It's not like the methotrexate that we use. It's not like the leflunomide that we use in rheumatology practice, that every visit you need to come with CBCs and aminotransferases. So routine blood laboratory monitoring is not indicated unless you are expecting some problems where prudence lies in switching. Then there is a direct question.
One comment on that, sir. I have shown you that AG has specifically said that while on long-term PPIs, you do not need to monitor calcium, phosphorus, bone density, and vitamin D level.
Yeah. Very clear. I think you had shown it very well, very well. Then there is a pointed question. Difference between Vonoprazan and S-omeprazole, which one is superior? Now, you are a gastroenterologist of repute. So this has to be a very, very nuanced answer on which one is superior. I mean, people talk about non-inferiority trials. So this is the question from Dr. Lokender Jain.
Yes. I think the answer is very simple. S-omeprazole is only one enantiomer of the PPI, isomeprazole. It is a S and L enantiomers. So basically, basic drug is isomeprazole and it is a S enantiomer. Now, this is again the same class as PPIs. As I think given a lovely diagram that I've tried to show it with animation, that PPIs will block the active proton pumps on the parietal cells, whereas vonoprazan is blocking the proton pump which are available on the surface as well as those who are lying dormant within the cytoplasm of the cells. So on one-to-one basis, it causes suppression of both inactive and active pump. Say after ingestion of the meal, say 60% of the pumps are active, 40% are sleeping. It's like a reserve force. Vonoprazan is going to inactivate those also. So overall one-to-one suppression will be faster and better and prolonged with vonoprazan. Given the choice, I'll always choose vonoprazan for judicious use.
Then again, iteration by Dr. Vikrant Desai. What are the common side effects of vonoprazan? Is it similar to PPIs? I think you have already mentioned that. Then again, about bone health and vonoprazan, can it increase fracture risk or osteopenia?
I'll give you, Dr. Rohini, I'll give you a corollary. Recently, I had an interview in a news channel regarding the flip side of drinking the RO water. You see, if you have been drinking too good a water, that is also detrimental because, RO water will try to take out all the minerals and will make the TDS to less than 100 in the water. That is total dissolved substances in the drinking water will plummet down to less than 200 if you're using RO. There was a controversy that once you remove all the chemicals, will it affect the health? Same issue came up over there. Your diet and your metabolism of the calcium is so different and so complex that it is not dependent on PPIs alone or the water alone to alter the homeostasis within the body. So use of the PPI on long term on epidemiological studies has a controversial relevance to development of osteoporosis. Having said that, I think as a clinician, it is prudent on us to use it only when it is needed. When it is needed and I am using, then I'm not worried. But when the patient has osteoporosis and I am using it injudiciously, that is where the alarm bell should ring into my ears.
Absolutely, very, very balanced viewpoint. And then we have head-to-head trials between PPIs and PCAB. And I think this data you have already shown, that there is data available in the literature on head-to-head trials, but these are all non-inferiority trials, and it is available in the literature. This is a question from Dr. Arindam. And then we have a question from Dr. Vikrant Desai. Can we provide vonoprazan in DMARDs or drug-induced gastritis? I think this NSAID-induced gastritis, the data is already available. The dosing was shown, 10 milligram of vonoprazan can be used, and entire course of therapy. The question is, can you give this considering the entire course of therapy? Unfortunately, rheumatic diseases like rheumatoid arthritis are courseless, limitless, timeless. There is no course. You escalate treatment or you de-escalate treatment. And as Dr. Arora very well said, you learn to be parsimonious with your drugs. Pill burden leads to a drop in adherence. The moment you give too many drugs, so one would be judicious. If you have a person who has acid peptic symptoms, you would give them these drugs. Long-term use has been mentioned. But if somebody is having refractory symptoms, I would not hesitate to get a GE consult. They would bring a skill set and occasionally they may discover something which you would have overlooked. So I would suggest that you see not with DMART so much, but with NSAIDs we face this problem. And the dictum now is treat the cause, not the consequence. So NSAID use in rheumatology practice with better disease modification has gone down. Even in ankylosing spondylitis, if you are using biologicals or JAK inhibitors, the need and necessity for this has gone down. It's only where conditions like osteoarthritis, which are mechanical in nature, that your medical treatments are insufficient, and there you need a friendly orthopedic surgeon to intervene. So we would use intra-articular corticosteroids, we would use effective disease modification so that the reliance on anti-inflammatory drugs goes down. Long-term use has already been mentioned. The data, as was mentioned, is for about 8 years. So we need to be, as the science evolves, we'll have more answers on this. Then we have Vijay Thorat. Can we mix vonoprazan with DMARDs? I've already answered this. Then there's a question. Can it be combined with antibiotics amoxicillin from Dr. Venugopal?
That is a very relevant question. And Dr. Rohini, if you recall that I had presented this network analysis from Japan, which was published in Lancet about a year ago, regarding the efficacy and utility of vonoprazan-based therapy for eradication of H. pylori. Now, H. pylori is a ubiquitous organism in India. Any patient you test for gastritis or so-called quote-unquote hyperacidity, you will find H. pylori. And every time you test them, they'll be positive. If you give therapy, it doesn't take away the bacteria. So this vonoprazan-based therapy coupled with amoxicillin. So you need to have, this is in the normal course of the event, if you're using PPIs, you have to use 2 antibiotics, typically clarithromycin and amoxicillin coupled with, say, pantoprazole or esomeprazole. That was the standard of care. But with availability of vonoprazan, one single antibiotic like amoxicillin and vonoprazan for a period of 2 weeks gives you 93% cure rate. That is the best thing we have available for treatment of H. pylori. Certainly, it can be combined properly with vonoprazan.
Thank you. And then there's another questioner about asking about risk of nephrotoxicity.
Yeah, in nephrotoxicity, let me again go back to the published literature on PPIs first. In fact, there has been some hue and cry about the chronic kidney disease being caused by PPIs. But the recent analysis has, I think, clearly shown, nephrologists will vouch for that NSAIDs usually do not cause chronic kidney disease. It is some of the patients who will develop allergic related chronic interstitial nephritis, which is a idiosyncratic reaction. So there is no dependent PPI related nephrotoxicity. That is in PPIs. There is no established side effect of vonoprazan for causing kidney disease. So on one-to-one basis, if you have a kidney disease, if you want to use PPIs, you should not back out. But again and again, I've been retreating. Use it only if it is needed. If it is needed, you are going to get striking a balance between the utility and long-term side effect. If you need to treat it for peptic ulcer disease or for GI bleeding and its complications, certainly it's not a contraindication in CKD, especially in short-term basis.
Then we have a question on use in children, infants, and pregnancy.
Yes. This is a new drug, as happens with most of the new drugs. You have to be really cautious. You do not know how would the developing bones or the formation of the new organ system will take it, both within the utero as well as in the early phases of development of the child. So one has to use it judiciously. As of now, it has not been approved for use in pediatric population, pregnancy, and the lactating women. Maybe with passage of time, like if you remember, Dr. Rohini, in HIV, the drug of choice was tenofovir, which was an antiviral drug, which we were never given, in our pregnant women with HBV. But learning from you people that in HIV, tenofovir is safe even in lactating mother. So we are now routinely using tenofovir for our pregnant women with hepatitis B. So with passage of time, I think should be available for that special subgroup of the population.
I think very well said. It's like the anti-TNFs. Now they are permitted for use in pregnancy and lactation. And 20 years ago, we would tell our patients not to get pregnant. Paternal exposure to methotrexate, now allowed. And we used to counsel our patients that if you want to father a child, you stop methotrexate. That all is history. And I think this is the evolution of medicine. And then there is a question which maybe the company can answer from Dr. Anupama. What is the cost of this medicine in India? Or maybe if you have an idea, or maybe somebody from the company.
I have the idea. You see, when the price was launched, then I was one of the consultants was approached to decide the cost by one of the companies. So after going through the literature and going through the nuances of its pharmacological actions and the advantages and the flip side over and above the conventionally available PPIs, I told them if they can plummet the cost to one half of the PPIs, you will have the curtain down for the PPI. Since they were also manufacturing PPIs, they didn't agree to it. So they have come halfway through. You will be surprised to know that it is cheaper than most of the conventionally available PPIs.
So any idea about the cost of 10 milligram or?
I think 14 rupees 20 milligram. In general, across the board. Different companies will have some difference in the cost. Overall, 20 milligram is around anywhere between 14 to 16 rupees compared to pantoprazole about 16 to 18 rupees, rabiprazole around 20 rupees.
Okay, and then a very interesting question on systemic sclerosis associated esophageal reflux. Yes, vonoprazan has been tried in this area. This is a niche area where we run into a lot of morbidity. With scleroderma patients, esophageal motility, reflux disorders are very difficult to treat. And this is an area where we have an unfulfilled area where we have a significant therapeutic gap. So vonoprazan has been tried. There is literature available specifically in the subset of patients with scleroderma and associated GERD about the efficacy where it scores over the conventional proton pump inhibitors. Then we have
that view, sir. Another advantage is, so this is if you remember, I gave you the list of the limitations of the present PPI. This is one of the limitations. Refractory GERD and scleroderma is one of the causes of the refractory gastroesophageal reflux disease, because even if you are suppressing the acidity, esophageal lumen does not have the enough capacity to contract and push the acid back because of the sclerosis in the submucosa. So that is exactly, you need more potent suppression of the acidity.
While like this, you see, what is this nocturnal acid breakthrough? I mean, for us as rheumatologists, this terminology, jargon, what is is it a fanciful term or is it a theoretical concern or a practical problem?
This is a practical problem. In fact, this was one of the most important unmet needs of PPI.
Can you elaborate on this for us who are not into this business? Non-gastroenterologist.
I would add some animation diagram which would have explained it better, but I'll try to simplify. So you have this concept of a cavity near the fundus of the stomach, which is not in direct continuity when you are lying down and moving around. The part of the fundus of the stomach has a pouch which has acid which does not get neutralized with the conventional PPI. And since it is in direct continuity with the gastroesophageal junction, so every time you tend to eat, as the lower esophageal sphincter relaxes, this acid pocket during sleeping and during lying down tends to go up into the esophagus. So you have an acid pocket in the fundus of the stomach near lower esophageal sphincter, which during the act of the swallowing relaxes, and because of the relaxation, you have an acid which comes up. This is something which has not been typically getting affected by the PPIs. This is where you need more potent suppression of acid, even stimulating the non-basal, non-stimulated acid proton pump also are getting suppressed with vonoprazan. So what it means is that in this particular cavity near the fundus of the stomach, which quickly pushes the acid up into the esophagus as soon as the lower esophageal sphincter relaxes, this particular part can be handled if you suppress the acidity completely by deactivating not only the proton pump which are available on the surface of the parietal cells because of the stimulation by meal, but also the inactive pumps which are available in the cytoplasm, which will migrate to the surface during stimulation of the nerve. And hence, this has been shown that nocturnal acid breakthrough is to be taken care of if you want to have a better relief in patients with reflux esophagitis. Earlier, we were using this drug called H2 receptor antagonist, which was the drug of choice. So people will give PPI in the morning before meal, and then at 6 p.m. early night dose at 6 p.m. a H2 receptor antagonist to take care of nocturnal acid breakthrough. Now, this has been now replaced by use of more potent suppressant of acid.
Thank you. Then we have many more questions. I think this has evoked, is there a disease-specific differential efficacy of proton pump inhibitors and PCAB? I mean, is there any disease where you would specifically opt for a PPI and another condition where your preference of choice would be a PCAB? Is there any particular disease?
No, if you want a more potent suppressant of acidity, like a patient who has a established peptic ulcer, a patient who has a complicated peptic ulcer, a patient who has Zollinger-Ellison syndrome, and patient who has recurrence of peptic ulcer, and patient who has established H. pylori. This is the subgroup who will definitely need a more potent suppressant of acidity. Since on scientific analysis, it has been clearly shown that this is good. Vonoprazan is superior to PPI. I'll choose the latter. But if I have to go for agents like PPIs for a limited period of time, the choice is for you to decide between PPI and Vonoprazan. And given the comparative cost and my knowledge of limited use in borderline condition, I'll still prefer Vonoprazan so that it becomes easier both in terms of the compliance, because it doesn't need to be given fasting, as well as the cost, which is competitive. So there is nothing too much to choose between the two. Better go in for better drug.
Then there's another question on adolescent patients with reflux symptoms and increasing problems in adolescents. So how safe is it, and what do you use in adolescents with acid pepsin disease?
Yeah, the DGCI is already given a clear answer that for the time being, the drug has been approved for the use in the population beyond 18 years of age. As I said, and as you very rightly put, the various examples of methotrexate and anti-TNF agent, that as the science evolves, we realize more and more the efficacy in the subgroup of the population. So if it is an adolescent, and if the weight is, say, in the adult range, I will not hesitate in giving PPI, even if it is not recommended. So for me, weight is more important rather than the actual size.
That's a practical answer. And then we have, does Vonoprazan affect blood pressure?
Vonoprazan, no, there are no reports of effect on the blood pressure, because the way it acts primarily on the acid production machinery of the body, I don't think it has any collateral flip side.
Then a pointed question on Vonoprazan in patients suffering with liver cirrhosis. I mean, liver cirrhosis is something which a gastroenterologist has to contend with. So Vonoprazan in...
Yeah, see, most of the guys, again, in patient with cirrhosis, there are two problems. One is the cirrhosis would mean a total disruption of the metabolic machinery of the body, which primarily lies in the liver, including CYP2C19 for PPIs and the other types of CYP which are meant for metabolism of Vonoprazan. Everything is going to be affected. In addition, patients with cirrhosis are more likely to have, they by default have immunosuppressed state and more likely to have problems of repeated infection. Again, that is a subgroup in which if you have to use it, you use it judiciously for a shorter period of time for definite indication. There is no contraindication to use in patients with cirrhosis. In fact, for control of the bleeding, there has been recent data to show that if the patient has a variceal bleeding or a peptic ulcer bleeding, Vonoprazan is better than pantoprazole in patients with bleeding peptic ulcer as well as bleeding esophageal varices. There is no contraindication to use. But again and again, the same thing, maybe to the, to the annoyance of the audience, that you use it judiciously. If you have to send one message, then after studying the whole science of acid suppression, after all, acid has been provided to the body for some defensive mechanism. Let's not try to trample that mechanism.
Then we have a question about combination with ranitidine in gastroesophageal reflux. Dr. Ashok Gupta would like to know, can it combine with ranitidine in reflux disease?
That is where Dr. Ashok, we started with the unmet needs of the PPIs, as Dr. Rohini very elegantly asked about the so-called nocturnal acid breakthrough or a fundal channel which is causing this problem. Now, that was meant to be given in patients with reflux who had incomplete response to PPI, which was given in the morning and night, and in the evening there was nothing which was covering up, and hence you would give an evening dose of H2 receptor antagonist. But that thing is gone with Vonoprazan because it will suppress the acidity completely for a longer duration of time. As I've shown you, the T half of PPI is 1 to 2 hours, whereas the T half of the Vonoprazan is 7 to 9 hours. You don't need to give it and combine it with ranitidine.
Then we have a question on patients of rheumatoid arthritis. What should be the dose of Vonoprazan? 10 milligram of 20 milligram. And I think that depends. If you are looking at long-term use, you would like to use 10 milligrams. And if you have a short-term use where you're treating proactively for ulcer, then I think you can use 20 milligram. And this dosing was shown by Dr. Arora in his slides. Long-term prophylaxis use, maybe 10 milligrams. Your thoughts on this, Dr. Arora?
Yes, long-term 10 milligram is in specifically, I showed you 3 groups in which long-term use is justified. Then I showed you in which the long-term use is not justified, and there are borderline indications. I think as a clinician, we should be concerned about the safety of the patient rather than trampling the acidity to almost null levels. We should use it judicially. God has given us a wonder drug. Let us make our best use of it in clinical practice.
Very reasoned reply. And then what is your patient feedback of Vonoprazan? This is by Dr. Guru Prasad, who would like to know that your patient feedback. These are early days for me, so I don't think that I can give you a first-hand answer. And maybe Dr. Arora, who's been, maybe can give an answer on this patient feedback from the horse's mouth.
To be honest, Dr. This drug has been in the market only for the last few weeks. So let me be honest, till to give you a clear scientific answer, we need to have more time. On paper, yes, but practically speaking, let's be more honest that we'll give you feedback maybe after a few months or a year. On paper, it has all, wishy-washy thinking.
And then Dr. Jagdish Gadagimath would like to know on limitations on the use of Vonoprazan. And I think again, this is, you have mentioned when not to use that and where you should be very circumspect. Then there's a question. Can we prescribe it along with antiretroviral drugs?
Yeah, so far as, see, most of the drugs which like PPIs or the conventional anticonvulsants or anticoagulants or proton pump inhibitors are being metabolized by the most commonly and frequently used cytochrome system called CYP2C19. Now, depending on the particular antiviral which you are using, antiretroviral drug, and the way it is getting metabolized, you have also to know where is this metabolized from. If there is a competitive inhibition, you have to avoid it. You can check it on the drug-drug interaction list. But to my knowledge, there is no contraindication to the use of these drugs if it is needed to be given as an acid suppression therapy in patient on concomitant antiretroviral treatment.
Then there's a question from Dr. Anil about co-prescription with DMARDs, NSAIDs. Is there any preference of choice of PPIs? And I think not really. Not really. There's nothing like that with rheumatoid. You need to use this enantiomer more, or that is better. You need to first see that can you cut down on your use of NSAIDs. Almost all drugs work equally, and there is nothing like lansoprazole would be better, dexlansoprazole would be less better, or esomeprazole would be better. So I think you need to factor in cost, you need to be judicious with your use, and where you have a difficult refractory situation, you can use the PCAB that is now available.
Situation, you can.
So now
Remember,
we,
Dr.
I
Rohini,
think,
we were doing our senior residency.
yes, please.
Yeah, you remember, sir, when we were doing our senior residency in medicine at AIMS, you would recall this drug called omeprazole came into the market. And, this is one of the wonder drugs, completely suppressing the acidity. Prior to that, we were having only one drug called cimetidine, which was launched way back in 1972. It was a drug called Tagamet, if you remember. Dr. Sama would procure it from
200
UK for
milligrams, maybe 4-5 times in a day. That's history. Yeah.
So that is the evolution which has occurred in front of our own lifespan, forget about 100 years or 50 years. In front of us, you've seen such advances in medicine. We should be thankful to the pharma industry. We should be thankful to the, drug discoverers and the scientists who are working on the, basic sciences to give us a good platform to work on when we are trying to handle our gullible patients.
I think we're now nearing the end of our time, and I would like to conclude by mentioning that peptic ulcer disease is common. So this, it's mandatory for all clinicians to be updated about this. And so also is the widespread use of anti-inflammatory drugs, and they are responsible for significant side effects. So we should be judicious in our use of drugs. The availability of Vonoprazan means that we have yet one more weapon in our arsenal to tackle these group of disorders, and it's work in progress. And I would like to thank Dr. Anil Arora for a very, very practical, very, very lucid presentation. I would also like to thank all the attendees for their questions, and last but not the least, the hetero group for bringing the first-in-class potassium competitive acid blocker to the country. And with this, I hand over to the organizers.
First of all, thank you very much, sir. On entire behalf of Hetero Healthcare, I would like to extend my immense gratitude to Dr. Handa sir and Dr. Anil Arora sir for accepting our invitation and making this webinar a very fruitful one. Thank you for this enlightening webinar focusing on the potential role of vonoprazan, its clinical efficacy and safety profile, its drug-drug interactions, and providing case-based approach, its practical use in managing acid-related diseases, as well as addressing all the queries patiently in detail. This was indeed a very informative and very interactive session for all our listeners. Thank you to everyone for spending your precious hours with us today. We promise to continue doing such scientific programs in future. Last but not the least, I want to sincerely acknowledge the countless efforts of our head office marketing team, the field colleagues, and the technical team for the seamless execution. Trust me, this wouldn't have been possible without the support of each one of you. Thank you all, and thank you, sir, again for the wonderful session on Vonoprazan. It has really helped us in improving our knowledge and the practical usage of Vonoprazan in different asset-related conditions. Thank you so much. Thank you, everyone.
Have a good evening, everyone.
Yes, sir.
Thank you.
Thank
so
you.
much.